Thank you for joining us today. We have a special event going on today. Of course, it's Suicide Prevention Month, but we have a special panel talking with us about rural suicide prevention. We'll get started in just a few seconds. A few housekeeping items. We do have closed captioning available. All participants are on mute. Probably figured that out. And what we do ask you that for those of you who are just joining us, that you rename your name in your display. And you can do that by hovering over, there's 3 dots and a mute button in the upper right-hand corner of your display. If you could rename yourself and identify what chapter or section of APHA you're coming from, we'd really love to know. We expect this to be a very diverse group. Of course, if you want to, you can just introduce yourself in the chat. We'd love to hear where you're from. We'd love to have participation. And of course, any kind of questions that come up, please feel free to go ahead and put in the chat as soon as you think of them. We're going to do our best to field all questions as the webinar goes on. We'll have about 5 minutes after the webinar for general Q&A, but it's not a lot of time, as you know, so we're trying to see if we can get questions addressed as we move forward. I want to thank our sponsoring organization, our sponsoring sections, for this special event. The mental health section of APHA, the Intersectional Council on Suicide Prevention, of course, and the Rural Topical Work Group. The three organizations together have come and have, I believe, put together an amazing agenda that it should be rich in discussion. For those of you coming in, just one more reminder, you're in the Rural Suicide Prevention webinar, discussing disparities and promoting state and local prevention strategies. Okay. We have 3 panelists today. We're very lucky to have Dr. Platt, Dr. Norad, and Linda Battaglia. I apologize, today's agenda. I did the introduction and started to go through some housekeeping. I'm going to let the panelists talk a little bit about what they're going to talk about, and we'll take it from there. So thank you for all of you putting items in the chat. It's good to hear where you're coming from or see where you're coming from. Okay. I'll introduce our first speaker. Dr. Platt is an assistant professor of epidemiology at the University of Iowa College of Public Health. His research focuses on changes in the population patterns of mental illness and suicide across place and time in order to identify key targets to improve mental health and reduce group disparities. He is currently the director of Problem Management Plus, a statewide program in Iowa to implement peer-led mental health support in refugee communities, and has actively led research projects to understand the role of school policies as determinants of emerging racial disparities in youth suicide. Our next speaker is Dr. Paul Norad. He's an assistant professor at the University of Cincinnati College of Nursing and a nationally recognized expert in occupational mental health and suicide prevention. He holds a doctorate in public health with a specialization in occupational epidemiology and brings more than 2 decades of nursing experience to his work. Dr. Norad has led and collaborated on numerous state and federally funded projects addressing mental health disparities, with a focus on developing and evaluating community-based interventions and examining suicide mortality in occupational and rural populations. We're also lucky to be joined by Linda Battaglia, who is a licensed clinical social worker with over 25 years in clinical and administration experience. For the last 6 years, she has served as a dual role of the Director of Mental Health and Community Services for Genesee County, New York. In this role, she oversees the mental hygiene system to ensure services are meeting the needs of the community for mental health, substance use, and intellectual and developmental disabilities. Additionally, she serves as the CEO for the Genesee County, New York Mental Health Department, which provides outpatient mental health treatment services to children and adults. So thank you for all who are here, for our experts to be able to share their insight, and for all participants for joining us today. Unless I've forgotten something, let's go ahead and get started.
All right. Thank you very much for the introduction, Andrea, and thank you all for being here today. It looks like from just glancing at the introductions, we've got a very large group of people with very diverse interests and locations and disciplines. So look forward to your thoughts, and I'm going to be kicking us off today. As Andrea said, my name is Jonathan Platt. It's a privilege to speak with you all today on this critical topic. The title of my specific talk is called Understanding and Preventing Suicide in the Rural U.S. I'll be providing some background and population level context, I think, before the next speakers discuss more localized work. Next slide, please. Next slide. I have two title pages. The objectives of the talk are first to describe the epidemiology of rural suicide, identify potential determinants of risk, and also understand what's been shown to work to prevent suicide deaths. Next slide. First, though, I want to remind you all that help is available if you or someone you know is having suicidal thoughts. You can call the National Suicide Prevention Lifeline at 988 or text the crisis text line at 741-741. Both programs provide free confidential support 24/7. Next slide. Okay, first section, epidemiology of U.S. suicide. Next slide, please. First, I want to situate the U.S. in the broader global context. Suicide is a significant public health concern in the U.S., and increasing trends place it in a somewhat unique context compared with trends in countries with similar socioeconomic contexts. This highlights the urgent need for work to identify and prevent determinants of suicide that to some extent are a uniquely American problem faced today. Next slide. In the US, the numbers are pretty stark. So in 2023 alone, there were over 49,000 deaths by suicide in the US, which equates to one death every 11 minutes. Beyond completed suicides, many more individuals struggle. So in the same year, 12.8 million adults seriously thought about suicide, 3.7 million planned an attempt, and 1.7 attempted suicide. Next slide, please. Within the US, suicide is consistently a top cause of death, ranked between the second and fifth leading cause of death among children through middle-aged adults. Next slide. And this figure just serves to highlight the suicide continuum from thoughts to planning, preparation, decision to act. Sorry, those question marks should just be arrows pointing from left to right, through attempt and finally completion. Not only does this figure serve to illustrate the complex processes that may precipitate a death by suicide, but also to show that there are many points at which we in public health might intervene to prevent a death from occurring. Next slide, please. Suicide patterns, deaths and suicides are not uniform, and rates vary significantly across group identities. Research, including ongoing work from my group, explores intersectional spatiotemporal patterns in the US. The link and the QR code, if you're quick with your phone right now, otherwise you'll get these slides, I think, afterwards. These will take you to this data dashboard I've just screenshotted here, where you can further explore these group differences if you're interested. Next slide. But we also find a very clear geographic patterning in suicide, with particularly high rates in rural counties, as shown in these maps, with the red shades sort of looking at the spatial distribution across the United States, and lower than expected rates in urban counties, shown in the blue. There are interesting racial disparities in these patterns, also that I won't really go into today, but please do check out the paper cited below if you're interested in the subject and interested in reading more. Next slide, please. Oh, sorry. Yeah, you can just click through that. There we go. The rural-urban disparities in suicide rates are pretty substantial. So in 2022, for example, the suicide rates in urban areas was 14.3 per 100,000, while in rural areas it was about 23 per 100,000, significantly higher. Furthermore, when we look at the trends in rate increases, rates have been increasing about 1.5 times faster in rural counties compared to urban ones. Next slide. And even within rural communities, risk can vary, rates and risk can vary quite a bit. So this is just highlighting a couple of groups with particularly high rates, including among middle-aged men and women who have high rates and are substantially higher in rural communities than urban. Um, Rates among youth ages 15 to 24 are also high, quite high, and significantly higher in rural communities. And importantly, suicide rates are highest in Native American communities and among veterans, especially those living in the rural US. Just to note, while national data on LGBTQ plus deaths is lacking in the US, research from a 2021 paper on past year suicide attempts among high school students show an alarming disparity. So this paper found over a quarter of lesbian, gay, and bisexual students reported attempting suicide. Over a quarter, 26%, a rate that was 5 times higher than their heterosexual peers. Next slide, please. Okay, so we'll talk about some known risk factors now. Next. So first, to just make the point that understanding risk factors for suicide is essential, although predicting them remains quite difficult. This is just to make the point that the age-adjusted suicide rate is substantial, but is quite low, really, when expressed, especially as a percentage, shown here. And even among those diagnosed with depression, which is considered to be a substantial risk factor, clinical risk factor for suicide, the rates are still about 7% or 1% for women. Just illustrating the point that it's quite a challenge to pinpoint who will act to complete a suicide. Next slide, please. Now, rural communities face unique factors that may contribute to suicide risk. Some of them are shown here. These include economic stressors, such as agricultural economic volatility, the threat of farm foreclosures and debt, and overall just limited economic opportunities, diversification, those kinds of things. Cultural barriers may be important, including values on self-reliance and independence, traditional gender role expectations, and concerns about confidentiality and stigma, all of which may affect and prevent help-seeking behaviors. Geographic isolation also plays a significant role, limiting transportation options, increasing social isolation and loneliness, and often delaying help-seeking behavior. And of course, healthcare access is a critical challenge in rural areas, punctuated by a severe mental health provider shortage, which means longer travel distances to care, limited insurance coverage, and a general lack of specialized mental health services. And another crucial factor in rural suicide risk is firearm availability. Next slide, please. So these figures just show the influence of firearms in suicide death rates. They dominate as a means of suicide overall and have been increasingly prevalent as a driver of rural suicide rates in particular. Next slide. Next slide, please. Thanks. It's important to acknowledge, although the ways that firearms are deeply integrated into rural culture, often seen as essential for activities like hunting, protection, and pest control, the geographic challenges of rural areas that include longer emergency response times, however, can significantly reduce survival chances when suicide attempts are made involving firearms. So effective means restriction, therefore, requires balancing safety measures with cultural sensitivity. Next slide, please. You can click one more time. So nonetheless, research shows that individuals in a home with a firearm have over 3 times greater odds of completing a suicide than those without access to firearm, all else being equal. And the figure here shows just how fatal firearms are when used in a suicide attempt, much higher than any other method. Next slide. So I'll come back to, I think, yeah, 2 more times you can click. I'll come back to firearms in the next section. But first, I want to just briefly acknowledge another potential risk factor, the role of digital technology in suicide. Social media and other related forms of digital technology can certainly harm mental health through cyberbullying, social comparison pressures, social isolation, potential contagion after a suicide death, and exposure to disseminated harmful content. On the other hand, there may be potential benefits may be gained from responsible social media use, especially in rural communities. Individuals there may gain access to supportive communities, intervention in the event of a mental health crisis, improved awareness and education around mental health and suicide risk, and personal interactions with individuals who have gotten through a suicidal crisis, which may enact sort of a reduction in suicide-related stigma and improve future help-seeking behavior. Can you click one more time on this slide? Yeah, so ultimately though, The research is pretty limited, so I argue that we need bigger, longer, and more detailed studies to really fully understand both risks and potential benefits of digital technology in relation to suicide and mental health. Next slide, please. Okay, finally, I'll end with some details on what works for suicide prevention. Next, please. Now, one of the most effective strategies here, coming back to means, is means restriction. So the data here are pretty compelling. I think among a large sample of people who made a near lethal suicide attempt, 70% of them made that decision to die less than an hour before their attempt, and a striking 24% made the decision less than 5 minutes before. Others have reported that about 90% of people who survive a serious suicide attempt will not die by suicide later, but by other means instead. So I think these data points just highlight how brief the most acute risk of suicide death period the most acute period of risk for suicide death can be, and thus the potential to save a lot of lives just by making it slightly harder to gain access to a firearm during that short period of time. Next slide. Fall nets, just briefly, are another example of effective physical means restriction, including on the Golden Gate Bridge, which was finished in January of 2024 after a long period of planning and debating. But since then, bridge-related suicide deaths have decreased by over 75% there, and researchers have estimated that the net itself will save approximately 286 lives over the next 20 years. Next slide. Now, another critical prevention area is risk assessment during healthcare visits. Research shows that 50% of people who die by suicide visited primary care in the month before their death, yet 85% of them had no mention of suicidal ideation in their record. Additionally, 40% visited an ED in the year before their death. Now, these data points indicate missed opportunities for intervention and the need for improved screening and documentation in clinical settings. Next slide, please. But to understand what works for rural suicide prevention, the Rural Health Information Hub, just shown here with the link, provides a valuable toolkit on suicide prevention, and they outline several key strategies. These include details of both comprehensive and also highly tailored suicide prevention programs implemented in communities, clinical settings, schools, and online even, including the 988 crisis line, for which national answer rates have improved and wait times have fallen, even with substantial rises in contact volume since it was launched in July of 2022. Next slide. The RHI program, the Rural Health Information Hub, has a program clearinghouse to share details about various programs and their target populations, summarized to some extent here. They include community awareness and general prevention programs and firearm safety programs, enlisting gun retailers and range owners as trusted messengers in the community. Ethnic and culturally informed programs have been crucial to work with tribal communities and incorporate their approaches for suicide prevention. And programs for high-risk populations include empowering students with strengths-based approaches and providing specific awareness and resources for those who face unique stressors like farmers and their families. Lastly, systems-level transformation aims for a broad systemic reach across key community settings. And next slide. And I'll end hopefully on a hopeful note with a success story, some more details of specific success stories. So these data are shown based on a one particular community. So in 2006, following a tragic cluster of youth suicides, the White Mountain Apache instituted a tribally mandated system of detailed reporting on suicidal ideation, suicidal attempt, and suicide deaths, as well as non-suicidal self-injury, adding binge substance use in 2010. Also in 2006, the White Mountain Apache initiated a program of universal, selective, and indicated prevention at the community, agency, school, mental health system, family, and individual levels, directed by a community advisory board and elders council. Called the Celebrating Life Project, the intervention included extensive community-level awareness and education activities, cross-agency suicide response planning and implementation of applied suicide intervention skills training, or ASSIST, school-level implementation of the Sources of Strength and American Indian Life skills development curriculum, suicide prevention programs, and strengths-based cultural activities led by Apache elders, community mental health system-level implementation of brief risk reduction and engagement intervention for all youths with suicidal ideation or recent attempt, followed by family-level skills training, life skills training, and finally, individual-level mental health follow-up services. You can see the results from this figure here. The program over a 5-year period led to a 38% decrease in suicide deaths across all ages, including a substantial decrease in youth suicides where rates had been going up the highest and where the suicide cluster had sort of started. The White Mountain Apache experience provides testament to the scope and spirit of research and intervention that's needed to effectively mount a response to the suicide epidemic in the US. As public health advocates, policymakers, and leaders, we know what to do for effective suicide prevention. We have the models for effective leadership and an implementation science knowledge base. What's required is leadership and a modest, though not insubstantial, public health investment. Next slide, please. So thank you for listening. I encourage you to use any of the resources I shared and to remember that help is always available. If you have any questions, please do put them in the chat, and feel free to email me if you'd like. Thank you.
Thank you, Dr. Platt.
Do you mind putting you did say you were going to put your email in the chat. We'll also have time at the end to share resources. But I'd like to introduce Dr. Norad from the University of Cincinnati College of Nursing. Hello.
Thank you, Andrea. Thank you, Dr. Platt. Next slide, please. So today I'll be talking about our efforts here in Kentucky to address farmer suicide. We began working on farmer suicide and what we call agricultural and even forestry suicide in Kentucky back in 2019 as a result of several state and federal funding efforts through pilot programs. We were able to obtain funding through the CDC NIOSH to address farmer suicide. Our program here in Kentucky through the funded project is called Building Bridges to Farmer Mental Health. And we also have other partners through the Kentucky Department of Agricultural, and Raising Hope, who's part of KDA here in Kentucky, as well as other strategic partners, particularly Western Kentucky University, Eastern Kentucky University, and then the Kentucky Department of Behavioral Health. Next slide, please. And next slide, please. And just a quick note, our project is housed in the Southeast Center for Agricultural Health and Injury Prevention, which is a NIOSH-funded center. What we've seen in the literature in terms of farmer suicide mortality is that farmers have experienced, so farmers and ranchers, we've colloquially grouped them as the farmers, have experienced persistent elevated suicide mortality. Farmer and manager rates are generally higher than the general population of males. In this particular figure, this looked at U.S. male suicide rates, male farmers as a whole, because there can be multiple farmers and farm managers on one particular farm operation, as well as those who are primarily responsible for the day-to-day farm operations. Next slide, please. As a result of looking at these rates, there was a statistically significant upward annual percent change in farmer suicide rates throughout the study period. Other researchers, such as myself and Dr. Rudolphi and Christina Miller, have explored the predictors of farmer suicide risk. Farmers generally experience unique stressors that are not observed in the general population, and these stressors are characterized as unpredictable forces, things that are really out of their control on a daily basis. These stressors include time pressures, machinery breakdown, animal behaviors that are uncontrollable, crop and livestock disease, for example, molding of grain in grain bins, crop cattle experiencing disease leading to their death. Ultimately, when these losses occur, farmers experience a loss in income, and also in many cases, a lot of farmers will not have their farm operation as its own entity or business, and sometimes there can be some intermingling of personal and family finances. In short, these stressors have been linked to increased anxiety and depression in farmers, particularly here in the U.S., as well as worldwide in Australia, the UK, Austria, and other areas. As we know, in healthcare, chronic injury and illness can lead to co-occurrent anxiety and depression, especially in the presence of chronic illness. And so farmers are at high risk for occupational injuries. It's one of the most hazardous occupations in the US, only second to the logging industry. In addition to those traumatic injuries and occupational injuries, there's a lot of musculoskeletal wear and tear through joint breakdown and arthritic symptoms and arthritic changes that lead to health problems. Farmers are also particularly vulnerable to other chronic illnesses. I've noted COPD, which is in the absence of smoking. It's attributable to animal dander, particulate matter, exposure to endotoxin from harvesting procedures, exposure to grain dust and other dust mechanisms that lead and contribute to COPD, noise-induced hearing loss, as well as, in particular, skin cancer and some other forms of cancer. Recently, we've also, as part of our project, explored barriers to help seeking in farmers who experience some of those underlying issues that Dr. Platt articulated with access to care. We see some increased barriers to help seeking in farmers as well, because the pressures of the farm, inability to take time off or feeling like they can't take time off, not having that personal connection with a primary care provider or being able to see their provider of choice, also contribute to them seeking help when they need it, in addition to some of the other stigmatizing factors that we often observe in rural and farm communities. Next slide, please. In contrast to all the bad things that we talk about, and we recently began shifting our project as a result of community and stakeholder feedback here in Kentucky's farmers, were telling us we're really tired of hearing about all the bad things going wrong. We know all the bad things that are happening. We have friends who are dying by suicide. We hear about it. And so we began incorporating the positive things of farming. And so there are positive things in terms of farming that we are working to capitalize on with farmers. And so farmers and their family members view farming as a lifestyle. It's not a job. It's something that they want to do. It's a part of their heritage and who they are. In contrast, when there's a threat of losing the farm, suicidality can increase because that's the loss of heritage and loss of identity. There's a positive sense of belonging in farmers and their commodity associations and within their community. We're working to capitalize on that. There's a sense of community connectedness, especially within the focus groups and groups that we're working with here in rural Kentucky. As Dr. Platt mentioned, we've received quite a bit of feedback before the project, throughout the project, and have continually tailored our prevention trainings to resonate with farmers and their families and within the rural community setting. We've also made those county specific. So it's not just Kentucky specific, it's very community specific and community centric, because the different rural communities have different needs, different types of farming, different perspectives. And then we're here in Kentucky, we're engaging multi-level supports. And so it's not only community supports, we're engaging state support through the legislator. We have a Raising Hope Day that is well attended by our state legislators and farmers and providers, that just shows appreciation for the farmers throughout the state. And so we also have supports through the Kentucky Department of Behavioral Health, the Kentucky Nurses Association. And so we begin prioritizing those multi-system supports and multi-system engagement. Next slide, please. And so essentially you can see our mission, and as you've heard, we've expanded that a little bit. But really the four foci of our mission and what we do to achieve that mission is we're training what we call mental health advocates. These are persons within the rural community here in Kentucky that we've recruited through our stakeholder networks to train those individuals to respond to farmers and rural community members who are in crisis, and also help us build those connections with rural and farm community members within the counties that we serve as a part of those project. In addition, we've provided a training to those mental health advocates called Farm Smart that really does the suicide prevention. So that's based on QPR as a result of feedback, because it's short, it's condensed, it's easy for them to deliver. And also a Farm Smart to address farm stress and connect with the different resilience factors that we see in farmers. And so it's connect those communities of care. We're also engaging in professional development and training nurses and mental health practitioners here in Kentucky in CAMS, which is a clinically based suicide prevention module. What we heard is a lot of nurses and mental health professionals did not feel like they had the training to be able to effectively engage with rural communities and farmers when they're in crisis, especially given the resource deficits that we see and that Dr. Platt had talked about earlier. And then the other thing that we're working on with our stakeholders is we're really working to develop an end-goal consortium to foster connection and build a strong network of care across those multi-level systems. And so what we found is we've been operating in silos and trying to put out the fires, so to speak. And so we're stepping back and saying, what can we do as a group to complement each other and complement each other's work? Next slide, please. And so I talked a little bit about mental health advocates and what we've trained them in. They have presented that in their community. We have heard direct feedback from our mental health advocates and from community members that they have been able to apply the skills that they learned in the Farm Smart training that was coupled with QPR and connect farmers, family members, and rural community members to suicide crisis care. And so we have had feedback from our community saying we have prevented suicides, and I've been able to identify people who were at risk for suicide. We've developed community action planning tools for our mental health advocates. Then the other layer of this, in partnering with Eastern Kentucky University, is that we have a telepsychology agreement. So if our advocates and community members identify anyone in crisis within the rural community, they can call our EKU crisis line and they get connected to services. And so they're not waiting 2, 3, and 4 months to be connected to a licensed psychologist or a PsyD in training and go through screening. They are screened within, if it's on the weekend, they're screened on Monday. If it's during the week, they receive same day or next day screening. And so we're really proud of that effort and being able to reduce some of those time delays. Next slide, please. And then here's just a menu of our professional development trainings. I've talked about CAMS a little bit. I've talked about QPR and Farm Smart. We are grateful we've connected with Be Sensitive, Be Brave. And so we are exploring or being able to pilot Be Sensitive, Be Brave in a rural community that is supported by the Kentucky Department of Behavioral Health, Be Sensitive, Be Brave. And so we're looking to roll that out statewide and working with the Be Sensitive, Be Brave group in Washington State to be able to provide some culturally sensitive tailoring. We're going through the focus group process to provide feedback, and so we're grateful for that partnership. We also partnered with the DBT Steps A group, Doctors Liz and Jim Mazza, and we're able to deliver DBT Steps A to a large group of agricultural educators here in Kentucky who are working with rural and farm youth inside the schools here in Kentucky in our counties. And the goal was just to promote adaptive skills and train those agricultural educators in DBT Steps A so they could perform just some upstream interventions in helping youth, manage that stress that they experience as just being a youth growing up in rural Kentucky, but also being part of a farm family. So we are grateful for these partnerships and opportunities and this menu of trainings that we have been able to cultivate. Next slide, please. And then we've talked about community connection, and this is just one of the great features of our project in that we're able to connect through a variety of social media campaigns. We have a quarterly newsletter. We have a presence with our stakeholders at large ag events like the National Farm Machinery Show, the State Fair, Fruit and Vegetable Growers Association conferences. And so we're out in the community connecting with farmers and actively engaging with them. Again, we're convening a state suicide prevention roundtable, and it's really bringing together researchers, those community initiatives, and those professionals who are sort of out on the ground engaging with people and just receiving feedback, finding out what we can do better, where they need support, and just finding out where our blind spots are and what we may need to look to address from a community part, because we know that gathering large surveillance on suicide and putting that all together at the state level can often be difficult, and so this is a good way to gather some of that information. And I'm going to move on. Next slide. And I think I have a movie here that I want to show real quick that showcases what we're doing with our Roots of Agricultural Resilience to highlight what we're doing in farmers. So if we could share that real quick, and then I'll wrap up my time. Should just be able to click on the link. Did it not embed?
I'm not sure that it embedded.
Okay, well, that is okay. We may have to skip it.
If you could share it in the chat, I could
apologize.
potentially open it up.
It's not formally published. I apologize. If you can get that opened up, that's okay. I'm going to keep moving. I don't want to utilize too much of our time, but this will be forthcoming, and I can share it with Shauna and Andrea and others just to highlight what we're doing to showcase just the resilience in farm communities and how there's just synergy across farming. And so lessons learned that we've experienced, just the stigma and lack of time can often hinder the implementation of our curricula. We've worked to improve materials. Communities consistently show interest and willingness to intervene. Some of the limitations still is farmers have not been able to access our telepsychology study services just because of lack of connectivity in the rural community. We've also had some small sample sizes in our research publications, so we're just working on that to expand our data collection. And then we just are continue striving to understand how to support our community-based mental health advocates who are really in the community and have their finger on the pulse of the community members, and then just give a collective voice for the community data and just share that collective voice and be transparent with our stakeholders and what we're seeing and doing. Next slide. And I think that's it. Thank you so much for your time and allowing me to be present. It's been an honor to present this information and project.
Thank you so much, Dr. Norad. I don't think I identified at the beginning of the webinar that I am a Kentucky native, so you're speaking to my passions and all the things that I care about. So thank you for all the work that you do. Next, I'd like to pass the mic over to Linda Battaglia.
Thank you so much. Thank you, Dr. Norad and Dr. Platt, for your information, and Andrea for moderating. I appreciate the opportunity to be on this panel discussion today, a topic near and dear to my heart. I was asked to highlight the work that we're doing here in the western part of New York State, which in Genesee County is a rural county. And for those not familiar with Genesee County, we're sandwiched between Buffalo, New York, which is Erie County, and Rochester, New York, which is in Monroe County. I'm going to be talking about our GOW Cares Alliance, and that's Genesee, Orleans, and Wyoming counties, all of which are rural counties. Orleans and Wyoming counties are our neighbors. All three counties are very rural, and just to give you an idea, collectively, the total population for all three counties is about 137,000 people, with Genesee County being the largest of the three, and having a total population of about 58,000 individuals. So we like to have our running joke here in the county, as there's more cows than people here in Genesee County. But next slide, please. With that being said, as you can imagine, as Dr. Norad just mentioned, the significant challenges that rural counties are faced with, some of our challenges is trying to have that far reach out into the community so that we can provide services, but also the barriers that our people are faced with in order to try to access services because we are so rural. And being in a smaller county, everyone knows that the degrees of separation are minimal. Everybody knows everybody, so stigma is extremely high in some of our counties. And so I'm going to talk a little bit about our GOW Cares Alliance and how this developed. Next slide, please. So back in 2017, 2018, Genesee County had one of the higher rates of opioid overdoses in the state. At that time, 38 to 40 individuals died by an opioid overdose, which is really high for our county. And so the county received funding in order to create an opioid task force. Now I'm talking about opioids, talking about substance use. However, we recognize that there's a significant overlap and some very strong commonalities and contributing factors with substance use, overdose, and suicidality. So the opioid task force was developed in 2017. It allowed us an opportunity to really look at the numbers, try to understand why the overdose rate was so high in Genesee County, and to really identify the challenges and the barriers and a prevention strategy and a response strategy in order to respond to these deaths. Next slide. So we're going to fast forward a little bit to just about 2 years ago. The grant ran out a little bit, funding ran out, and it gave the GOW Cares Alliance an opportunity to kind of reconvene and identify, okay, where do we want to go now with this opioid task force? And we were able to redesign the GOW Cares Alliance. And as you can see, CARES stands for Community Action for Recovery, Education, and Support. We recognized that we were much stronger together, that these counties, rural counties, had a lot of similar challenges, and that we had a stronger voice and a further outreach into our communities working together. So that's what we did. The partnerships were stronger, the collaborations were already built. So we kind of continued with it, and we broadened our scope of outreach into the community, incorporating some additional areas of current concern like stigma, like suicidality. We also recognized that there was, being in a small county, that all the providers and the people that were at the table for these different topics were the same individuals. So why not convene and put everyone together, such as the suicide prevention coalitions? The counties, Genesee, Orleans, and Wyoming County, all have their own independent suicide prevention coalition to meet the needs of their own individualized communities. However, collectively, we also have GOW Pathway to Hope, Genesee, Orleans, and Wyoming County, where we can have a broader reach when it comes to suicide prevention and education efforts. And again, some of these overlap with GOW Cares Alliance. So sometimes we're hosting events for suicide prevention efforts. You can see here we have a community-centered approach. We want to have a pulse on the current trends, and we want to involve people with lived experience. That peer support services really goes a very long way in our communities. For current trends, we also in Genesee County and Orleans have a fatality review board that I'm a member of, and I conduct the next of kin interviews. Just from that, I have a pulse hearing from family members who have lost someone to suicide and or overdose, that the commonality between suicide and substance use was extremely high. And where could we have intercepted that individual before taking that fatal overdose? It also brings to question thinking of a fatality review board and next of kin interviews. Specifically, where does the suicide factor come in when somebody is using and they do die from a fatality of an overdose? Almost like playing a game of Russian roulette. But I think that's probably a topic for another panel on another day. Addressing barriers to access, right? We want to promote community awareness and understanding. We want to educate the community on how to navigate the system and how to access our services. We're equally independently but collectively trying to address stigma because it is a rural area and people know everybody. So somebody coming to a mental health clinic, the odds are of them knowing somebody here is pretty high. So we really try to incorporate more confidentiality and really get out into the community to educate our community about the services that we have. We promote the 8 dimensions of wellness: physical, emotional, social, intellectual, occupational, spiritual, environmental, and financial. We're also really trying to bring in our faith-based leaders into the rural counties and bringing them into the Gal Cures Alliance and events so that people feel comfortable bringing in their spirituality and their religious affiliations as well. Next slide, please. The Gal Cures Alliance has steering committees and the membership really overseen by myself and my colleagues, other directors of community services, Danielle Figuera from Orleans and Kelly Dryja from Wyoming County, as well as our public health directors in Genesee, Orleans, and Wyoming. Genesee and Orleans share public health director. Another reason why the Gal Cures Alliance makes so much sense for us. I want to talk about funding really quick. Because the DCSs, myself and my colleagues are involved in Gal Cures Alliance, we're able to tag some unallocated state aid funding to ensure that the Gal Cures Alliance continues in their mission and their vision, which is community outreach for suicide prevention and overdoses. We also have a really good pulse on our community and what our needs are of the community, and so we can incorporate that into Gal Cures Alliance as well. Next slide, please. These are some of the work groups, and I know we're running short on time. The work groups, these are all spearheaded by our committee members, our community members, chairs from the facilities, including DCSs, myself as well. We try to really hone in on very specific areas about what the community needs: education, holding public events, figuring out what the community trends are with utilization of data from the Department of Health in all 3 counties. We have a resource hub. We're always trying to push safer choices and, again, incorporating faith-based. We're really trying to make sure that all the perspectives from the counties are being brought to the table, as well as individuals with lived experience. Next slide, please. This is just a photo of the Overdose Awareness Day. We have law enforcement at the table. We have peers at the table, providers, substance use, mental health. Sometimes we have county legislators. It really is a community wrapping around each other in the community to prevent suicide, to prevent overdoses. And then we have some additional community events, which is on my next slide. If you could, yeah, thank you. Some of the things that we're working on specifically to provide services to the community, again, putting events out to the community instead of the community coming to us. One that's not mentioned on here that I do want to highlight, Dr. Platt had identified the firearm factor, and ownership of firearms in rural counties is extremely high. So meeting individuals in rural counties where they're at, particularly knowing that the suicide rate in rural counties is also higher. We held a lead therapy program, which was mental health and the Gal Cures Alliance going out to a firing range and focusing on men's mental health, meeting them where they're at, talking about lethal means restriction, talking about how to access mental health services, trying to break down barriers and stigmas. It was a little bit controversial, again, but being in a rural area, we really needed to meet our community members where they were at. It was very well received. Over 60 individuals participated, specifically focusing around men's mental health. So in addition to this, we're focusing on trauma-informed care as well as adverse childhood experiences and trying to incorporate that into our program as well, and pushing that out into the community, making sure that providers and members of the community are trauma-informed and use safe language as well. I went very quick. I spoke quickly, but we're running out of time. That's all I had for my presentation. I thank you very much for giving me the opportunity.
Thank you so much, Linda. huge amount of information for a very challenging issue. I just want to encourage all participants to put questions in the chat. We do have time for a few questions. While people are formulating their questions, I just want to thank each of the sections for sponsoring this special event. The APHA Mental Health Section, the Intersectional Council on Suicide Prevention, and the Rural Topical Work Group. If you are interested in joining any of those groups, we'd love to have you and we'd love to have your insights. If you don't know about the organization, about the subgroups, I can tell you a little bit. The ISCSP, as we're known, the Intersectional Council on Suicide Prevention, we're a multidisciplinary team of public health professionals working to collaboratively across APHA to reduce suicide. And the topical working group is very similar, working across APHA to address rural issues, including suicide prevention. I see we have a question in the chat addressing this stigma. What specific actions are you doing? And I can't quite tell who that question is directed to, but Linda, perhaps you can take a shot.
Yeah, no, sure, I appreciate it. It's a great question. So, I think as the director of community services, we had a really good handle on what we thought the stigma was based on. Whether it's not in my backyard or NIMBY, as some people like to call it, just accessing services with some opioid settlement funding that flows through my office. We were able to conduct a little bit of a research study with listening sessions through the National Opinion Research Center. We had researchers coming in and talking with specific groups, first responders, law enforcement, county legislators, providers, people with lived experiences, business owners, to ask them what their opinions were when it's specific to stigma relating to substance use, harm reduction or safer choices, suicidality, alcohol and drug use. Those just concluded, and we know stigma is significant in our rural areas. What we're looking to do now is, now that we have some solidified information, and that's not just anecdotal, we are going to develop a strategic plan, probably some advertisements, some PSAs. We're going to hold some educational sessions about stigma and how to break down barriers relating to stigma. We had some schools participate, so we're going to also be involved with some like half-day superintendent days with some school systems, as well as get in with some of the student bodies, talking about mental health, talking about suicidality and how to access mental health services. We've expanded our services to include officer wellness programs and first responder wellness programs, because suicide rate for first responders and law enforcement is also significantly high. So we're really trying to just keep the conversation very much alive and active and ongoing, with the use of the Gout Cares Alliance, all of our providers in the counties. So that's what we're trying to do to combat stigma. We're also pushing 988, and going to the firing pin and the firing range was a great example of kind of breaking that stigma and that barrier for men's mental health. To have mental health professionals go to an area like that and say, let's talk about stigma relating to mental health and firearms, and how can we engage in some lethal means education. Like, it was actually very well received. So I hope I answered your question. I could keep going, but I know we're time sensitive. So.
And looks like you have another question for you, Linda. What partners were essential for making the lead therapy event a success? And you said that it was controversial.
So the partners for lead therapy was really the suicide prevention coalitions, specifically in Genesee County. That was one of our independent events. And, we have a lot of partners on our suicide prevention coalition, Genesee County, including members of and staff from the VA. And so we're a grassroots coalition. So with that grassroots, you start to know everybody. And it started in a conversation with the owner of the firing pin out in one of our towns. And the conversation just naturally and organically occurred to say, let's do this. And so our Suicide Prevention Coalition took the lead. The owner of the firing pin, embraced it, advertised for it. We had, like I said, over 60 individuals RSVP. You throw some food in there and people are going to show up as well. I think it was a little controversial because of gun violence, because of gun rights. However, that wasn't what we were looking at. We wanted to educate, and considering firearm is the highest means for lethality for individuals who die by suicide, we needed to go to that source. We needed to talk about lethal means restrictions. So as much as it was controversial, it was very well received, and it was a really, really good turnout. And it was well supported. So I think part of that is that fear factor of why are we doing this and what's happening, and that immediacy to say, like, we have to say, no to firearms, but at the same time, we're in a rural county and gun ownership is high here. So we have to get creative. So thank you, Brett, for your question.
We have one more question, at least thus far. What communication strategies have you found effective in your work with rural communities for reducing stigma and encouraging help seeking? I think this question probably could apply to all presenters. But I'll start with Linda first to see if you have a. Is there a short answer for that?
What communication strategies have found? I think doing that research study with the listening sessions really started an opportunity to engage in conversation about, hearing from our community members, not just me as the professional, but hearing from the people who live here. What do they think the barriers are? That was a really good first step. I think in rural communities, it's prevention, it's education, and it's going out to those faith-based leaders. It's going out to the churches. It's going out to the parent-teacher nights. It's really just trying to get involved and doing as many tabling events as we possibly can. And I think so far this year in 2025, we've probably attended over 30 events in Genesee County alone.
I can just speak to um, my experience with other related projects, but I guess first, sort of just second what Linda said around being in the community and engaging sort of as collaborators and not, one way or here I am the expert to talk about this. And one of the really nice things that you learn when you do that is people want to, there are different ways of talking about things, and language is really important. Words really matter. And hearing what people say are the challenges that they're facing. I think everyone mentioned enlisting, sort of partners in firearm shooting ranges and meeting people who are potentially at high risk in those venues. It may not be that men at a shooting range want to talk about suicide or even mental health, but maybe they want to talk about the stress of their life, the burdens that they're faced with, those kinds of things. So I think that's another benefit from working within communities as collaborators, and you really learn ways that can be sort of productive to have those conversations, and maybe ways that aren't going to be as productive.
Yeah, I think those are excellent comments and great strategies that we have used. We also, with our mental health advocates, they provide tailored feedback. Most of them are farmers and are within the community. So any messaging we have, it is being filtered through them. We are adapting it based on their feedback. And then they are the persons delivering the messages in their communities. It's not me. I get that. I grew up in a rural Appalachian community in Tennessee, and if you're not part of the community, you're not part of the community. And that's not a negative or a positive. It's just the reality of rural living in that area of Tennessee. And we see that in Kentucky. And then the other constraint, we as researchers cannot be in the community. Some of our communities are 4.5 hours away, and so it's hard to be present in that. And so they are the one communicating all those messages. And so it's originating from people who they can see on a weekly or even a daily basis within their community, in addition to all those great things Dr. Platt and Dr. Batiglia said.
Wow. How incredible. we don't have time for questions, but I am typing in the chat my email address so that any additional questions can be funneled my way. I said earlier in the chat that the webinar recording as well as the slide deck will be provided via Lead, as well as posted on the APHA webinars page. Any last remaining things to say before I say thank you to you all? Thank you all of you for your time and your thoughtfulness and giving your attention to this very important topic. And we appreciate you.
Yeah. Thank you so much.
Thank
Thank
you.
you.